early November and then started to increase the week before Thanksgiving. Now, we've always anticipated that there would be some increase with the holidays, people being indoors more, gathering with non-household members. But now we also have the additional concern around the Omicron variant, and I'll talk about that at the end of this talk, but we are starting to see that uptick. So the answer to when can we take our masks off is still not yet. This is a screenshot from our SC-DHEC vaccine dashboard. The upper row of figures is people, the percentage and the number of people who have had at least a single dose of vaccine, and the lower row of figures, people who have had the completed vaccine or fully vaccinated. About a little bit more than 50% of all South Carolinians ages 5 and above have completed vaccination. And we've had more than 36,000 children in the age 5 through 11 group in South Carolina have had at least one dose of vaccine, and some have been completely vaccinated by now. I don't want to talk just about COVID. I think we also need to recognize that this might be a bad influenza year. You know, on average, our 5-season average for influenza in South Carolina is about 3,500 cases, with a high of almost 7,000 cases in the 2019-2020 season. And that seasonal average also includes about 2,600 hospitalizations and 122 deaths. But compare that to what we saw this past year. This past year, we had 116 cases of flu, 154 hospitalizations, which sounds confusing, but you know, a person could be hospitalized, discharged, and then re-hospitalized, and 18 deaths in the last season. We think because we will not have the benefit of some cross immunity with cases of flu last year, we fear that this year influenza may be even worse. Here's where we are with influenza-like activity by week. The top row is this year, 2021 through 2022. You can compare that to previous years, with green is minimal, light blue, low, then moderate and dark blue are high activity. So we're just at the very beginning of our influenza season. And to bear in mind, what are the complications of influenza? I mean, in addition to 10 days worth of feeling lousy, shaking chills, fever, aching all over, lying in bed, there can be a number of secondary conditions that result, because influenza lowers your resistance to these other conditions. For kids especially, it can also lead to sinus and ear secondary infections, bacterial infections. And for kids and for adults, there's worsening of chronic disease, you know, poor control of diabetes, congestive heart failure, asthma, all having increasing problems. And influenza, if you get a viral pneumonia or a secondary bacterial pneumonia, that could have chronic ongoing sequelae with decreased pulmonary function, with fibrosis or bronchiectasis resulting as a complication of influenza. There are some more rare inflammatory conditions such as myocarditis, pericarditis, and rarely encephalitis, but that plays a big role in why people may die or have chronic disease from influenza. Just recently, there was an article published in the New England Journal of Medicine looking at the fact that there's an increased risk of stroke or heart attack within the week after influenza, testing positive for influenza. They were looking at admissions for acute MI, heart attack, and they were 6 times as high during the 7 days after laboratory confirmation of influenza as compared to a control interval. So there may also be complications of influenza that lead to increased clotting issues and just general inflammatory issues. Here we have the map of the United States for influenza. This is the week ending November 27th, and South Carolina is still having minimal ILI activity, but look around the rest of the country. Yes, most places are low. However, what is going on in New Mexico is hard for me to sort out, because in fact, we look at the rates of vaccination. New Mexico and South Carolina are kind of midland. Maybe 50% of the eligible population is vaccinated, but it's about the same. So, when we look at what parts of the country are more highly vaccinated, we're still not at goal for influenza. You know, even the places that are highly vaccinated are vaccinated maybe 66%. So we've still got a ways to go with vaccinations for influenza. The ACIP recommendations for 2021-22, basically, there's a vaccine for everybody. Allergic to eggs, there are egg-free vaccines. Don't like needles, there are nasal inhalation vaccines. There are vaccines that are not live virus that are available for pregnant women. There's basically a vaccine for everyone age 6 months and older. All of the vaccines that are available this year in the United States are quadrivalent, meaning that they're going to cover both strains of A and influenza B that we think will be circulating. And just a reminder that yes, you can give influenza and COVID vaccines on the same day. Just give them in different locations, give them in 2 different arms. Defer vaccination if someone is febrile or more than mildly ill, or if they're in quarantine or isolation for COVID. But, you know, we can definitely give booster doses or primary doses of COVID vaccine at the same time as the influenza vaccine. I've included the link to the MMWR that has detailed recommendations, precautions, contraindications for administration of influenza vaccine. And as I said, all of them will cover all of the virus strains that are thought to be circulating. Here's a key question. Clinically, you can't distinguish COVID, influenza, or RSV. I have seen handouts that propose to suggest you can distinguish, for example, from the common cold, but it's a lot tougher when we're talking about COVID, flu, or RSV. And it's important to know. The only way to know for sure is to test. And the reason we want to know is because there are treatments for all of these, and they differ. CDC estimates that influenza over the past, since 10 years, 11 years, since 2010, has resulted in almost 800,000 hospitalizations and 12,000 to 61,000 deaths annually across the United States. And similarly, RSV, granted, more of a problem with children, but RSV is also a killer of older adults. About 58,000 hospitalizations with 100 to 500 deaths among children less than 5 years old. And these are not just kids who are developmentally disabled or have other chronic medical problems. These sometimes are perfectly healthy kids. The risk of not knowing, of making guesswork about distinguishing these diseases is high. There is a test that is a combo test that will, in single swab, tell you the answer for flu A or B, COVID-19, and RSV. And as I said, the reason to know is because there's something you can do. For influenza, there are a number of different antivirals that differ on their costs, side effects, precautions. But just to remind people that these antivirals reduce duration and severity of disease. But of course, the best, an ounce of prevention is worth a pound of cure. The influenza vaccine would be the best solution. In terms of prevention or treatment options for COVID-19, I've got some good news. Just recently, FDA has authorized the Lilly monoclonal antibodies. That's the BAM and ETI monoclonal antibodies that are given by IV infusion for all ages, including neonates, including newborns who are at high risk of severe disease with COVID-19. The pills that everybody's talking about, the Merck Molnupiravir, which is 30% efficacious in preventing hospitalization, and the Paxlovid, the Pfizer pills, 89% efficacious in preventing hospitalization, they're probably not going to be authorized for use in 5 through 11. They might not even be authorized for adolescents younger than age 18. And they're not going to be available for several weeks at least. In contrast, Pfizer vaccine is available now. We have greater supply than there is demand. Pfizer vaccine has proven itself efficacious. I have a typo here, not just in preventing hospitalization, 91% efficacious in preventing any symptomatic disease in ages 5 through 11. And the link to the Nature article that describes that study is at the bottom. RSV, we don't have a vaccine for. There are vaccine studies ongoing. There are certain antivirals that might have some proven efficacy, but really treatment of RSV is symptomatic. I know talking to pediatricians that they often have said that their diagnosis of RSV is a clinical diagnosis. But this year, I think all the more we need to be encouraging testing to determine is this RSV, influenza, or COVID, because it makes a difference in terms of isolation, quarantine, makes a difference in terms of when they can go to school, makes a difference in how you do how you treat them, because there are interventions that can be given in the first 10 days of COVID-19 and the first few days of influenza as well. South Carolina has a very high cumulative rate of COVID-19 cases per 100,000 children. There are a couple of reasons for that. One of them is we do have a younger population than some other states, for example, Florida, but it's also because South Carolina considers, statistics consider a child anyone younger than age 20 or younger. Some other states use age 19 and younger or 18 and younger, so that tips us up a little bit. But I think it's still, nevertheless, likely that we do have a genuine increase, cumulative cases per 100,000 in children in South Carolina. And some of that relates to vaccination in adolescents, and some of that relates to mitigation measures. Some states were very good with wearing masks in the schools and taking precautions. I think that was less true in a lot of places in South Carolina. So what is the scoop about vaccine for COVID-19 for children ages 5 through 11 years? 91% efficacy in preventing any symptomatic disease. That's really awesome. That's about as good as you get with a vaccine. The big concern that came up with the vaccine for adolescents was the higher incidence of myocarditis, especially in males ages 16 and 17. In the vaccine study, the phase 3 studies for ages 5 through 11, of course, there were 0 cases of myocarditis, because you have to administer this vaccine to at least hundreds of thousands of individuals before you're likely to find a single case of myocarditis. So what can we predict? What can we anticipate around vaccine-associated myocarditis for kids age 5 through 11? Well, there are a couple of reasons why we might anticipate a lower rate in this age group. Number one, they don't receive the same dose of active ingredient. They receive 10 micrograms of the active ingredient, the spike protein gene, as opposed to 30 micrograms for the adolescents and adults. Also, we know historically that age group actually has very low risk for myocarditis from other causes, from autoimmune disease, from circulating viruses, from medication interactions. But even putting all that aside, if we made a guesstimate that the rate of myocarditis for 5 through 11 years was the same as the vaccine-associated myocarditis for the next age group up, age 12 through 15, that particular rate is 4 per 100,000 doses of second doses of vaccine for boys, and 0.4 per 100,000 second doses for girls. There are about 440,000 children ages 5 through 11 in South Carolina. If we vaccinated every child in that age group in South Carolina, we could anticipate probably fewer than 10 cases of myocarditis. And in contrast, the cardiac effects of COVID-19 disease or multi-inflammatory syndrome of children, serious and include myocarditis. You have a greater risk of myocarditis from COVID-19 than you do from the vaccine for COVID-19. We know that 94 children aged 5 through 11 in the US have died from COVID. The idea behind, yes, that's a low number, but it actually works out to be the 6th leading cause of death during the Delta surge for kids in this age group. We want to prevent death number 95. And again, to revisit the concern many parents have of feeling my child is healthy, has a really low risk of having severe COVID. Well, I can argue right back, they also have a really low risk of myocarditis. And if we were to compare those two conditions, Hospitalization and an ICU stay for COVID, that's because your child is severely ill. They need ventilatory support or they need extracorporeal membrane support. They're often a long hospital stay with a long recovery time. Whereas a hospitalization and even an ICU stay for myocarditis is so they can do cardiac monitoring to look for arrhythmias. It's non-invasive. It's usually 2 to 5 days in length. These kids completely recover from mild myocarditis. Let's move to talking about the Omicron variant. This map is probably already out of date. I just put it together this morning. It's already widespread, confirmed cases in 45 countries, widespread around the world, every continent except Antarctica. And it, as of December 6th, it was in 17 states. I think it's now in at least 18 states, including our neighboring state of Georgia. It has not been detected in South Carolina. SC-DHEC is certainly doing some genomic sequencing through PHL, also sending samples to CDC. I know many of our clinical partners and academic partners at Clemson, at MUSC, at Prisma Health, they are also doing sequencing. So we've not found Omicron is here yet, but it seems likely that it would spread here. I want to back up, though, and talk about some basic biology to help understand what is the concern with Omicron, what we know, what we don't know, what we anticipate. The concern with Omicron, and the reason it really hit headline news, is because it has over 50 new mutations. And when I say new mutations, I mean new compared to the original Wuhan virus. Some of these mutations we've seen before. Some of these mutations are shared with Beta variant, with the Delta variant. But of greatest concern is that this new variant has 32 mutations on the spike protein. And it's the spike protein that is the key in the lock, so to speak, for the virus to attach to a cell and enter, invade, infect a cell to then replicate itself. The new variant has also 10 mutations specifically on the receptor binding domain. So even from the very beginning, just looking at the molecular biology of this variant, it was thought it's probably going to spread more quickly. When I use the word mutation with the general public, I just can't imagine what people envision as a monster mutant. When we're talking about mutations in the SARS-CoV-2 virus, the virus that causes COVID-19, we're talking a switch out of one amino acid to another. So for example, the mutation D614G, that's the amino acid at that 6114 position, got switched from aspartate to glycine. Some of those switches in amino acid don't mean really anything at all. They don't change the shape of the protein and they're not important. They're not significant. Others substantially change the shape of the spike protein. So going back to just basic biology, right? To make a protein, you have a string of amino acids, but it doesn't stay like a string for long. Instead, it starts to curl into a more complicated protein structure. And you can imagine if you changed one of those amino acids, it might not change the structure at all, or it might change it substantially. And that's the concern with Omicron. I'm not going to go through everything on this slide, but this is why scientists are greatly concerned, virologists and immunologists. There are 15 mutations, 10 to 15 mutations in that receptor binding domain. So that's why they think it's going to attach more easily. It also has a new combination of unusual mutations that may help it evade antibodies. Because if you change the shape of the protein, it may cover up some sites where antibodies usually attach, but now those antibodies can't get in there to attach. And there's even some mutations that are in fact deletions, loss of amino acids, but that may mean that it helps to evade vaccine. But look at how complicated that spike protein is. Sure, there are changes in those spots, but most things have not changed. And when we're talking about your immune system responding to the spike protein or responding because of vaccination, there are a great many other places where vaccine can attach. What do we know epidemiologically? This graph is showing the different variants of concern in South Africa. And I'd ask you to first just focus on that purple line. That's the Delta variant. So the Delta variant started to increase back in April in South Africa. And like us in the United States and in Georgia in August and September, running through until mid-November, it was far and away the predominant variant. But look at that red line, that's Omicron. So that was first detected in late October in Botswana, in fact, but it was South Africa that did the laboratory work. But look at how quickly it has taken over. Look at how quickly it has taken over from Delta. That's epidemiological evidence for Omicron being able to outcompete Delta, which none of the other variants has, because it can spread more easily. So we've got some new mutations, some new combinations, some mutations we've seen before that we know about that do increase transmission. So we've got evidence for increased transmission. What about vaccine? It may be that vaccine will be less effective in preventing infection, but there's still good evidence that vaccine would prevent severe disease. Now, this is preliminary evidence, still pretty early on in this pandemic, but we're not seeing in other countries that have Omicron variant, we're not seeing a lot of severe disease. But it's smart to think ahead. And multiple vaccine companies are, number one, evaluating vaccine effectiveness in the laboratory, in test tubes. But they're also working on developing multivalent vaccines that would cover the Omicron variant as well, just in case. And that's the beauty of messenger RNA vaccine technology. I mean, we know exactly, as you can see along this graph, we know exactly where each of those mutations are. And we have the molecular biology technology to go in there and switch out those amino acids to match this map of the spike proteins for Omicron. Will we need to, though? Perhaps not. CDC has changed their recommendation with regards to boosters. The recommendation now is that everyone aged 18 and older should get a booster dose of vaccine 6 months after completing their primary series. And Omicron is the reason they recommended a booster. Let's go through a couple of scenarios with individuals who maybe have already had COVID. Are they as protected? Do you need the COVID-19 vaccine if you already had COVID? Well, certainly if a person has already had COVID, we know that that confers a certain degree of protection. The question has been how long that protection would persist. And there is good evidence, I'm just including 2 links, a study in the United States and one out of Israel, that if you already had COVID, you can cut your risk of reinfection in half by getting vaccinated. So if you had COVID, get vaccinated. You more than double your protection from reinfection. Now, that's the information we had during Delta predominance. There's some new information and new concerns with Omicron. So overall, in general, reinfection, somebody had prior COVID, reinfection within 3 to 6 months has been rare with the other variants. But new surveillance data from South Africa shows that that might not be as true for Omicron. There is an increased risk of reinfection associated with the emergence of Omicron. The rate of reinfection with Omicron was 3 times higher in South Africa than it was with Delta. So there's sincere concern that infection-induced immunity might not be as effective against Omicron. And here's just the figure that is showing that. On the top graph, you're seeing there surges of primary infection during the year. It's actually quite similar to what we saw in South Carolina and in the United States as a whole. The bottom graph is reinfections. And the rate of reinfection the surge kind of follows the surges with the primary infections until the very end where I've got that red arrow. That is their very recent surge in reinfections and right now in South Africa, Omicron is more than 75% of the new diagnoses. So this is a surge specifically associated with reinfection and with Omicron. So will vaccine work against Omicron? Well, here's some of the laboratory data, and this is pretty late breaking. This is preliminary evidence with Pfizer vaccine in the laboratory. What they did was that they took sera from people who had been infected with Omicron, and they looked at whether they divided up individuals who had been vaccinated, people who had been vaccinated and had prior infection, and they found that 2 doses of Pfizer gave a level of neutralizing antibodies, but it was certainly much lower than with the original Wuhan strain. So that's those yellow orangish lines. So D614G, that's the original strain, and Omicron, you can see the antibody levels really dropped. Now, South Africa doesn't do boosters, or they're not doing boosters yet, so we can't look at the effect with boosters, but they looked at what if you had 2 doses of Pfizer plus a prior infection. So that's kind of like a proxy for a booster, that you had 3 doses of exposure. That did give a much higher level of neutralizing antibodies. So the preliminary evidence does support in the laboratory, we've got evidence for getting a booster. And remember, antibodies are like first responders. They're not the only thing in your immune system. I mean, this is reassuring, but there's also killer and helper T cells. They kick in later. And there, again, there is evidence.
Dr. Kelly, your mic is out.
Oh, no.
There's back. It's back.
I'm sorry. I don't
Go.
know.
So no problem. You just
Okay,
for a second, go ahead and pick right back up. You're good.
Thank you. I won't touch anything. T cells kick in later. So, vaccination is not an all or nothing thing. It is highly likely that vaccine will be protective against severe disease, hospitalization, and death. We don't have any data yet on Moderna and J&J, but I'm sure they're working on it. So who do we think will get Omicron? Well, certainly the vaccinated are far more protected than the unvaccinated. So we expect a surge among unvaccinated. We expect a surge among people who had prior infection and are relying on it because they found prior infection kept them pretty much protected during Delta if they had been infected with another strain. But it looks like it will not give them that same level of protection with Omicron. We're seeing higher number of cases among young adults, adolescents, not surprising, who are not vaccinated, not surprising because they have more social interactions, whether that's at school or at work. And we are concerned about a surge in young children who are either not vaccinated or under 5 who can't be vaccinated. So we do anticipate we always anticipate some surge with the holidays, but we do anticipate a great increase in cases if Omicron starts to spread to South Carolina, and it's highly likely it will. Here's the other big question of the day, though, is Omicron more severe? Number one, there's no evolutionary advantage to kill your host. Virus wants to spread more easily, not necessarily put you in the hospital. So there's an advantage to mutate so you spread more easily. There's no real advantage to mutate to kill. So that's just theoretical, but I think it's worth thinking about because people should not panic about Omicron, but they should take actions to reduce their risk of getting it. We know that in South Africa, they are seeing milder cases of Omicron, milder cases of disease. They're seeing more cases, but it's milder. Now, is that because the vaccines are working, or is it because Omicron is in fact a less severe disease? Or is it mild because South Africa has a much younger population than the United States? It's going to take some time to sort that out, but we'll probably have some answers to that within the next few weeks, considering the number of cases that are being seen worldwide. And just to finish with the flu, just like people ask the question, really, do I need a COVID vaccine if I already had COVID? Do you need a flu shot if you already had the flu? Yes, there are different strains of influenza circulating. The flu shot covers all 4 strains. So it's possible for you to have one strain and then get a different strain the second time around. And that second episode of the flu can be just as bad as the first with the same risk of complications. So just a reminder, get your flu shot and your COVID shot. You can get them both on the same day. I saw there's some questions in the chat box, but I also want to remind you, anybody, if you have a question that comes to you later, doesn't get answered tonight or anytime in the future, there's my email address, kellydjm1@dhec.sc.gov. You're more than welcome to email me your question. If you've got a question, somebody else does as well. So thank you
so much. Thank you, Dr. Kelly, for that wonderful information. Very thorough look at the state of things with COVID and even with the flu. I'd like to bring in Amanda Santamaria, who is the president of the South Carolina Association of School Nurses. Amanda, what are you seeing in our schools, and what is a message you'd like to share with parents and community members and grandparents who may be hesitant or may be wondering whether or not they should be having their kids go and get this vaccine? What are you seeing at the school level, and what are your recommendations?
Sure. So to kind of echo what Dr. Kelly was just speaking to, we definitely are seeing an increase surrounding the holidays. That's kind of to be expected in the school setting. But what has kind of been concerning to us is that for both students and staff members, we are seeing an increase in cases in those who are fully vaccinated. So our recommendation is just as she said, get the booster, continue to social distance, continue to mask, and really just place some emphasis on the fact that we're not out of the woods yet. We really need to continue to be cautious as we move through the winter holidays and into the new year.
Thank you so much. And Sherry East, president of the SCEA, why is it so important for legislators, stakeholders, and folks who are in charge of our schools to understand the information that Dr. Kelly shared with us? And what can we do collectively to protect ourselves and make sure that our students are safe and our educators are safe as well?
I think most of all, we want to get accurate information into the hands of our parents so they can make the best decisions for their family, hearing from medical experts, not from social media, not from their neighbor, not from, whatever source they're getting all the misinformation that's out there. I appreciate everyone on the call, and especially DHEC for getting, putting your hotline out there. Please get a hold of her. But we know firsthand that we can't have any more disrupted school. Like, we really need as many children face-to-face at school as we can. So the less amount of time we spend on quarantine, the less amount of disruptions we have, is the more, then we get more information and content into the heads of our children. So you don't have to worry so much. So that, just as a measure to keep our folks safe, get your flu shot, get your vaccine, get everything you can to protect your family, and really seek the guidance of your pediatrician, of DHEC, of your medical experts, and check with them when you have questions.
Thank you so much, and such a great piece of advice there. A lot of people are getting their advice on YouTube or on Facebook or whatever. They're hearing things from people that simply are not the experts, and that's why the SCEA is brought on. We did a live stream earlier a few weeks ago with the state's leading pediatricians, and we've brought Dr. Kelly, who is the assistant state epidemiologist, to talk today. Going back to you, Dr. Kelly, I think one of the big frustrations that I'm sure that you have and a lot of folks in your arena have is the misinformation that folks have bought into. And I think there's a lot of misinformation around vaccines in general. Can you help sort of allay some people's fears around vaccines? I mean, most of us have taken vaccines, whether it's polio or whatever. We take these vaccines and it hasn't really been a huge issue. And all of a sudden it's become this big political issue, and this issue that's really preventing us from being safe and from kind of moving past this. Can you help folks kind of sort of demystify vaccines so that they're not so scared of them?
I think part of the issue is that people feel a loss of control. And anytime there's that loss of control and fear, people lash out and are more reactive rather than thinking through something. And so the first step is, acknowledging the concern they have and asking honestly, what is their specific concern? And then to answer that specific concern with data. I saw an interview with Dr. Fauci, for whom I have great respect, in which somebody asked him about, is it, and this was a celebrity asking him, saying to him, I don't know, I don't like vaccines. I'm not so sure I want to get vaccinated. And he said basically, oh no, you don't know me, but believe me, you should trust me, get vaccinated. And I don't think that's a helpful message. I'm concerned about a just trust me message. I think we need to answer with facts, point to data where we have them. Anytime I make a statement like, Omicron spreads more easily, how can I say that? Why would I say that? Or if I say the risk of myocarditis would be low in 5 through 11, how can I say that? Well, I can say that because we've had millions of kids who are adolescents and adults who have been vaccinated. We know those numbers of myocarditis for those age groups, so we can extrapolate from that. So I think number one is acknowledging. We got to acknowledge people's fears and concerns, ask them what is the particular thing, and then if you don't have data to support it, to try and get an answer. That's part of why I want to always include the scientific papers, because people, I think, do seek information, but they have trouble distinguishing between reliable sources. And the recommendation I always make, if you read something on social media, okay, ask, can you tell me where you got that? Can you point me to the source? And when they point me to just a magazine article or news blogger, I want to ask from that blogger, can you point me to the paper that demonstrated that? Otherwise, this is hearsay. So I think asking people's concerns, addressing their concerns. But the other thing that's unique about this vaccine is that it still feels just too new, and that people are worried that it was rushed. And to them, I would say, we have a lot of experience with vaccines overall in America, right? We've been vaccinating for smallpox for more than 100 years, more than 150 years. We've been vaccinating with many, many different vaccines for more than 50, 70 years. So we have a lot of experience about what side effects come with vaccines. And most side effects, if they're going to occur in the first 6 weeks. So people who say, I don't know what might be the long-term effect of this vaccine, the long-term effect is protecting you from COVID-19. We have not seen abnormal long-term effects from other vaccines. There have been rare things like Guillain-Barré syndrome, but there have not been new mysterious long-term effects. So pointing to how do we know what we know? What is our history? And also the point that, this vaccine, the COVID vaccines did not suddenly spring on the scene from ground zero starting in January of 2020. SARS-CoV-1, the original SARS, severe acute respiratory syndrome, back in 2003, they started work on vaccine right then and there. So we've got more than 17 years of basic science research going into this vaccine.
Thank you. I want to go ahead, and there's a couple of questions that I'd like to read. Victoria Ladd asks, do you anticipate that we will need to change the definition of fully vaccinated to include boosters?
Right now, the CDC definition of fully vaccinated is 2 weeks after your second shot of Pfizer or Moderna, or 2 weeks after your single shot of Janssen vaccine. That might change. I don't have any inkling. I don't have any special insight that CDC might change that definition. In one sense, that definition is for employment purposes. And so it is not necessary. Their recommendation is that you should get the boosters. Everybody should get the boosters. The definition of fully vaccinated, I think, is a little bit more for the sake of employment. I would only be giving my personal opinion. I have no inkling that that's going to change at this time.
Okay, and English Myers asks, will we still consider someone that has had COVID to be immune for 90 days?
That's an excellent question and remains to be seen. So right now, we consider somebody who's had COVID-19 to be relatively immune. The risk of reinfection is really low in those 90 days, unless they have an immunocompromised condition. Will this be different with Omicron? Maybe. The data that I quoted from South Africa with reinfection did not distinguish between people who were reinfected within a different time period. Those studies are going on right now. So right now, we are still considering somebody immune for 90 days. And remember, in South Carolina, more than 99% of our new cases are still Delta. So, so these rules still apply because it's Delta that we're dealing with.
Dr. Kelly, I have a question just for myself. this has been on everybody's radar for a while now, and I think a lot of us are wondering when is this going to end? How is this going to end? In your opinion, first of all, what can we do to bring it to an end? Second of all, is it even possible that it's going to end, or is this something that's going to simply be with us, like the flu shots and the flu is every year? What do you envision? I know it's an opinion and it's a projection, but you are one of the experts, so I'd rather ask you than somebody of mine who's not an
And I
epidemiologist.
can share what the experts, scientists, virologists, immunologists around the world. There's consensus, pretty largely consensus, that this is not going to be likely eliminated or eradicated like polio or smallpox. It is too widespread. It also infects many other species as well, many other animals. So it's unlikely to be completely eliminated or eradicated. The best way we can end this pandemic is to get more people vaccinated. But it is true that having COVID a couple of times is going to induce some natural immunity too. So we don't have to hit 100% immunization in order to bring this from a pandemic to an endemic level. Now, what does endemic mean? Endemic means it's always there. It's part of the background noise, just like influenza. And I think most experts currently feel that the pandemic, with hospitals being overwhelmed, with people having severe disease, can be brought under control with vaccination. But can it be completely eliminated? Not likely. More likely to become endemic, meaning that you've got a certain amount of cases every year, gets worse in the winter, and some unfortunate people do get severely ill and die, but that they are usually the more fragile among us.
Awesome. Oh, it's not awesome, but thank you for sharing that. That was really enlightening. Sherry asks, if a person got the J&J shot, what is the best way to get a booster? The mixed shots, or is it another Johnson & Johnson shot?
It's some evidence. If you got J&J and you want to get your second dose, you have a choice. You can get J&J, Pfizer, or Moderna. There is some evidence that Moderna will give you the highest neutralizing antibody level. Now, neutralizing antibodies aren't everything. I think any of those, a second dose, would be effective in preventing severe disease. But there is some data to say that Moderna, not the booster Moderna dose, not the 50 micrograms, you're going to get your second shot, you would get the full dose, the 100 micrograms of Moderna. There is some evidence that will give you higher levels of neutralizing antibodies, and that Pfizer will give you neutralizing antibodies in between Moderna and a second J&J shot.
All right, thank you. Amanda, I want to bring you back. A lot I've heard, and this is just anecdotal, there's a local school that's has gone through 6 school nurses over the past year, and I can only assume that has to do with the stress of managing this pandemic. Tell us a little bit about what school nurses are going through and how immunizing young people would make their jobs a little easier.
Sure. So, as you mentioned, I was on the podcast and we kind of spoke about this. School nurses their role has shifted completely as a result of COVID-19. Just like educators have had to kind of be flexible and adapt, school nurses have really taken on a lot of new roles and responsibilities. A lot of that is obviously the day-to-day upkeep with positive cases in the school, with contact tracing. Obviously, individuals who are vaccinated have, more protection against an exposure. And so that changes what the quarantine looks like for them. So the more students and staff members that we have that are fully vaccinated, the more students and staff members that can stay in school every day. I don't know that would necessarily lighten the workload of our nurses, because they are still always going to have their typical work plus their COVID work now. But it would certainly help the overall picture of keeping students and staff in schools, which is really the ultimate goal for all of us here, is to make sure that students can be in school learning face to face. And, our school nurses have always, even long before COVID-19, felt that healthy students learn better. And so the more students that we can get vaccinated, the less community transmission we have, can help our schools overall. We've also seen an issue recently with students who are experiencing ill parents at home and family members and grandparents. And that's obviously been going on for the last 18 months, but we are seeing a spike again around the holidays. And so our nurses struggle with that as well, and trying to support their students who have a family member in the hospital suffering with severe COVID symptoms, or a family member who may be at risk of death. And so it's just a challenge for us. We just ultimately would love to see, the pandemic come to an end and get more of a stable environment so that our students can go back to some sense of normalcy.
Thank you, Amanda. Sherry, we just saw the Sarah's supply and demand report come out recently. I think it was last week. It was released. We've seen over 1,000 teacher vacancies here in South Carolina alone, and continued number of people leaving the profession. How do you feel? What is your perception? You have your ear to the ground and are talking with educators all the time. What is your perception in terms of how the pandemic and how the state's response to the pandemic could potentially be impacting those numbers?
Oh, I think it absolutely pushed some of our folks out the door. We had a lot of I would say not working retirees, let me say that, a lot of full-time teachers that were eligible for retirement that thought they were going to stay a few more years, that decided, hey, this isn't worth it. My own health is compromised, or I have someone at home that I'm caring for that's compromised. So I think we have seen a lot of the vacancies are due to the pandemic, that, COVID pushed them out a little bit earlier. Personally, a lot of our members, would call and say, oh, I've had my years in for a while. I could have done a couple more, but I'm just not going to risk it with COVID. And then we also saw that was one piece of it, but the other piece was that teaching virtually or teaching in person when you just didn't feel safe. So you had to make a decision whether you were going to take on that virtual challenge, or even the dual modality was so stressful. So we've seen a lot of folks that were already stressed pre-pandemic and questioning their, profession, whether, this was what they wanted to do, or if it's worth it anymore from the working conditions standpoint. So we're hearing a lot of that again. I mean, a lot of folks that you can retire at 28 and they last till 30 or 35, 40 years. That was not uncommon to hear teachers say, I taught 43 years and then I retired. But that is not the sentiment right now. It's pretty much the slogan is 28 and done. If I can just make it to 28, I will retire and find something else to do. And you can retire. I mean, you'll be in your 50s at 28 years old. So you can easily go pick up a different career or do something and live on your retirement in another part-time job. So it definitely has made an impact. And it's really, we keep saying over and over, what's best for children? Are we doing what's best for children? As parents, we ask that, I hope, every day, from what kind of clothes they wear, what kind of, household you have, and that kind of things. But, I think we in the education community and legislators, and we need to really get down to, are we doing what's best for our children, and what do we need to do to make sure they have the best education and a healthy, safe, you are so right. Healthy kids learn best. We know that with hunger. We know that with you don't learn very well if you're sneezing or you have the sniffles or you're running a fever. And so many times our parents send them on to school. They have to go to work. They don't, they send them on, and then there's no one there when the school nurse calls and says, hey, I need you to come pick up Sally. There's nobody to pick up Sally because the parent can't take off work again. So there's so many layers to all of this. But I did have a question for the school nurse kind of around ratios and class size. Teachers, we have a class size, a recommended class size. I know there's a class size for guidance counselors, is a class size. Is there a caseload size that they want school nurses to have? Because it appears to me that with all the extra duties you have at this point, should we be looking at multiple school nurses for our bigger campuses in light of all the extra things that you guys have had to take on? And is there such a ratio that exists for you and healthcare professionals?
Sure. So in the school nursing sector, there is not a set ratio. Our national association used to have a recommendation, but they've moved away from that just because different states and different districts do things so differently. I know personally in the district that I work in, we kind of evaluate it based on school size and then also student acuity. So if we have extremely medically fragile children, they would potentially have a nurse designated to cover their classrooms or their specific classroom. We do also, at most of our larger schools, move to having a second or a third nurse. in an ideal world, we would have multiple nurses in every building, because obviously there are hundreds of children in every school. And the more nurses we can have to lay eyes on them and assess them, in addition to all of the COVID work, would be fantastic. The tricky part for us is that we are still not at a point in South Carolina where every school has a school nurse. So we really would like to see that happen, where at a minimum, every school building that has children in it face-to-face is staffed with a nurse full-time, because we really feel like every student deserves to have a school nurse, as you mentioned, just to evaluate them when they're not feeling well, do hearing and vision screenings, check them for mental health issues, health and wellness, nutrition, things like that. So we would really like to see that happen, and we hope that we can move towards that as we move forward.
Thank you so much. I'm going to give the last question to Dr. Kelly. Dr. Kelly, if there's a parent who happens to watch this of a 5 to 11-year-old, and they've been on the fence about whether or not to go ahead and get their child immunized with the COVID vaccine, and they're kind of wavering, hearing stuff online and misinformation, what would be your plea to them? What would be your concise argument to them to convince them to get their child immunized?
Depends upon their specific question. I'm always willing to be a resource for all of you as well. If someone wants to email me directly, I'd be glad to answer their questions. I have talked to individual parents on the phone. I mean, I know that one person at a time is labor intensive, but you're never talking to one person at a time. They go home and they talk to their friends and their family. So your message always goes further, but it has to do with their really specific reason. What is their specific, why are they on the fence? Because, and that makes all the difference, because sometimes they're on the fence because my child is a healthy child. I'm not worried if she gets COVID. They're not going to get seriously ill. It's no big deal. Okay, but if you got them vaccinated, they wouldn't have to quarantine next time they're a close contact to another kid in school. Oh, hadn't thought about that. Or, what about those rumors about fertility? Those rumors about fertility are exactly that. They are rumors. And I've got tons of data I can give you to show that there has been no decrease in fertility with receiving the vaccine. Things like unintended pregnancies occur in the same rate among young women who are vaccinated versus who are unvaccinated. We've got lots of data that vaccine is perfectly safe during pregnancy, no increase in stillbirths, et cetera. But pregnancy and COVID are a really bad combination. So, I guess that's not addressing the 5 through 11-year-olds, but that's more the teenager kind of question. But I guess the other question is about myocarditis. We estimate that, myocarditis is going to be really low in this age group. But even if we said it was the exact same rate as the ages 12 through 15, we're talking, imagine, this is the analogy I've often used. Imagine a stadium filled with 100,000 people, all boys between 5 and 11, and you vaccinate all of them. Then you're going to have, on average, 4 cases of myocarditis. That would be mild. And if you had that same stadium filled with all girls, it would be less than 1 case of myocarditis. But what would happen if you had a stadium of 100,000 children, none of whom were vaccinated? Well, we've seen it at any given time. We have dozens of children in the hospital with COVID-19, many of them in the ICU, many of them on ventilators. And so even if they don't die, they go through a heck of a lot before they are discharged from the hospital, as opposed to 1 day of a sore arm and a tiny, truly tiny risk of myocarditis. So it depends on what their concern is.
I appreciate that. And if you have specific questions, Dr. Kelly has given us her email address. It's kellyjm1, that's the number 1, at dhec.sc.gov. That's kellyjm1 at dhec.sc.gov. I want to thank Dr. Kelly, who is the Assistant State Epidemiologist at DHEC. I want to thank Amanda Santamaria, who's the president of the South Carolina Association of School Nurses, Sherry East, the president of the SCEA, Beth Poore, who is the Outreach and Education Coordinator for Immunization at DHEC, and Colleen O'Connell, who is our Public Affairs Specialist at the SCEA. Thank you all for coordinating tonight's event and being a part of it. And we hope that everybody who's listening will share this information. It is good information. It is factual information that needs to be spread instead of a lot of the misinformation that's out there. And if you'd like to be a part of our movement at the SCEA, please visit our website at thescea.org or join thescea.org. We'd love to have you be a part of our movement to deliver the type of schools that our students and their teachers deserve. Thanks so much for tuning in tonight. Thanks again to our panelists. Have a great evening. Good health, everybody.
Thank you all so much. I appreciate your help and support.
Oh, you're welcome. Thank you.